morning to all of you. We welcome you all for this month clinical meeting. It's going to be from the Department of Haemto Oncology as well as from the Department of Pediatrics. The first talk is going to be delivered by Sridhar Gopal. Interesting case vignettes in different formats. Over to you.
So basically, what I meant here is the millions, lakhs, and thousand. So the real wealth for the underprivileged. So this is what I meant by millions. So it's about because we do have plenty of the millions of RBCs in every drop of blood, and lakhs of platelets and thousands of WBCs. So these are the real heroes basically. So these are the cells which comes into action. So only because of this we survive. That's what I meant here. So a very good morning to one and all. Again, it's my privilege to be a part of this clinical club meeting. And this month, being a hematology department CME, I'll be trying to address cases related to hematology. So these are the spectrum of problems what we encounter on day-to-day basis. So any difference in cell lineages like RBCs, WBCs, platelets, we do come across. So when it comes to RBCs, we are all aware any hemoglobin less than 12.5 in male or 12 in female, it's called as anemia. Whereas the same when the hemoglobin is more than 16 in female and more than 16.5 in male, it's called as polycythemia. And thrombocytopenia, we all are aware the normal platelet counts ranges between 1.5 to 4.5 lakhs. So any lesser than that is called as thrombocytopenia. More than 4.5 lakhs is called thrombocytosis. And leukopenia, again the normal WBC count ranges between 4,000 to 11,000. So anything lesser than that is called as leukopenia. So even more significant is what we call as neutropenia, because many times these patients will be having a lesser WBC count, but still the patient may not have any symptoms because of the neutrophils which are there. So whenever we see a WBC count, we always think in terms of neutrophils. What we calculate is basically ANC, that is absolute neutrophil counts. So anything less than 1500 of ANC is called as neutropenic. So these patients are extremely prone for infections. So again, we come across like lymphomas, leukemias on every day, myelomas, MDS, there's myelodysplastic syndrome, bleeding disorders, thrombosis, primary immune deficiency, and autoimmune disorders. So coming to, I will start with the cases. So again, my humble thanks to all the departments here, because hematology is one such department which most of the patients are referral patients. So whenever some suspicions happens from other departments, they send to us and we dig in like from everything. We will evaluate. Finally, we turn up to some sort of diagnosis. So many times it's like it's not clear cut snaring at us. So all these has to be evaluated from from every step onwards. Sometimes when the WBC counts are very high, it is very easy to say it is leukemias, but many a times there will be some like normal WBC counts, normal platelet counts, normal even mildly low hemoglobin like a hemoglobin of 10, where we tend to pick up lymphomas and leukemias. So I just try to give some glimpse on all the cases here. So all these are very subtle things which we picked up and finally landed up in some diagnosis. So coming to the case number 1 is basically a 60-year-old gentleman who came to OPD to medicine department with excessive tiredness and EC fatigability for past 1 month. This is the only symptom which is extremely non-specific. We all are aware these malaise can be because of anything. Sometimes viral induced, sometimes fibromyalgia, could be because of anything. And the patient also had a dyspnea and exertion like NYHA class 3 for past 10 days. He also had history of loss of weight, loss of appetite. Again, all these are vague symptoms, nothing specific to hematology. But most of our patients, at least more than 80% of our patients, will be having such symptoms. In that way, it is very difficult to pick up any patient based on the symptoms alone. So otherwise, the patient never had any history of fever, which is typical of any hematology malignancies. And the patient never had any abdominal pain, any chest pain, or any history of any bleeding manifestations. Again, which is very typical of any patients with thrombocytopenia. Especially with malignancies like leukemias, we do see many patients with the bleeding manifestations. So this patient never had any sort of bleeding or fever. Again, the past history had well-controlled hypertension and diabetes. So clinically, on examination, the patient had severe PRR. He also had bilateral axillary and inguinal nodes. So again, now this gives a glimpse that the patient could be an hematological patient. Still, this is much more common in even infections like TB, etc. So the routine investigation, this was the investigation. We can see it is a severe pancytopenia. The hemoglobin is 6.7. So that's why the patient is severely pale. The WBC counts on the outskirt, it looks normal. It's like 4,600. But again, platelet counts is extremely low. It's only 6,000. So it's not a 6 lakhs, it's 6,000. It's only in thousands. So this was a differential. So again, differential, if you see with the polymorphs, that is the neutrophils are only 16%, and the lymphocytes are close to 54%. Again, this gives some more clue that we are dealing something related to hematology related. So again, further basic workup like direct Coombs test, which was negative, the reticulocyte count percent, which was normal, which shows that it's a relatively productive marrow or is a normal productive marrow. So when continued with biochemistry, so this you can see the uric acid is extremely high, it is 14.2. So the create was almost slightly higher, it's 1.3. The LDH is 1078. The rest of the biochemical parameters like iron, ferritin, total bilirubin, and everything within normal limit. So again, this gives a glimpse at there is some highly proliferative maybe lymphomas or leukemias which is underlying, which is having that like PLR and multiple lymph nodes which was there. So this gave us some more clue. So again we proceed with again basic infective etiology workup, which was negative for all. Dengue, scrub, viral and lepto, everything was negative. So the peripheral smear, again it showed a leuko-erythroid blood picture with the neutropenia and thrombocytopenia. Sometimes, many times we think that the peripheral smear will reveal anything, but it's not so. Especially when the normal cytical, maybe the cell counts are nearly normal. Many times the morphology may not be that much feasible in peripheral smear. So again, our pathologists are is like extremely good in the diagnosing. So they have given us the leukoerythroid blood picture, which shows there is something underlying marrow. So we need to proceed with marrow. So this was ultrasound images which showed multiple nodes and moderate splenomegaly. So all these have gave some clues that there is something underlying as far as hematology is concerned. So we did marrow. Marrow was extremely hard marrow, completely packed marrow, so we were not able to get any aspirate, so we got only the imprint. Again, so now I am sure that we are dealing something with hematology. So this was the imprint which showed all these lymphoma cells in the marrow. So again, if the tryphin is completely packed with all these abnormal cells, so this was the tryphin. So we were waiting for the IFC to get the final diagnosis. Again, the flow cytometry was done, which the gated population only 12%. Usually it should be more than 20% to say whether it is a leukemia or lymphoma. Most of the time, sometimes this we will be picking up with the flow cytometry. But this patient, because of the imprint was very low, like the aspect was very minimal, hardly no cells was there in the aspect. So we were not able to get in flow cytometry. However, it showed some more clue again. It is some sort of lymphoma in leukemic phase, resulting in completely packed marrow. So this was the IFC. Thanks to Dr. Sridhar sir for all these images. So the IFC, if you see, the CD20 was strongly positive. So now we are sure it is a B cell pathology. Again, there's all these leukemic markers were negative. I'm not highlighting all these here because of time concerns. The CMYC which was done is extremely positive. Again, the Ki67, which is the proliferative capacity, was strongly positive. So now we are dealing with some sort of extremely potential or highly aggressive lymphomas occupying the marrow. So this was the PET CT then, which showed multiple nodes elsewhere. There was nodes in the both side of diaphragm, axilla, cervical, and everywhere. So because nothing was conclusive, even the IHC, because the CMYC was only positive, further investigation like molecular is required for this patient. So we went ahead with molecular testing, which showed the fish, that is the fluorescent in situ hybridization, which was positive for T814 translocation. Only this gave the diagnosis for us. So now this patient, what we're dealing with is the Burkitt lymphoma. So Burkitt lymphoma, for a basis of understanding, it's a lymphoma for usually for the pediatric age group and young adults. So Burkitt lymphoma in this age is extremely rare. So this we were able to pick up just because of high index of suspicion with other complete workup, what we can say. Because many times in hematology, it's not a clear cut maybe snaring at our eyes. So we need to evaluate from step by step, ultimately resulting in Burkitt lymphoma. So then the management part, we were given some sort of chemotherapy. This patient, because elderly, we cannot go aggressively, but this patient with Burkitt lymphoma ultimately requires aggressive chemotherapy. Some patient may require transplant also. So this patient, because of age and other general condition, he was given some modified dose intensive regimens like R-CHOP, and the patient tolerated very well, and the chemotherapy also was going on very well. So far he has completed almost 3 cycles. So if you see, this was the platelet count at presentation of 6,000, and after the first cycle you can see the platelet count drastically improved to 6 lakhs. So just a single cycle of chemotherapy is going to change the life of the patient, and now the patient is completely good enough. He is coming on regular basis. In the meanwhile, he also sustained multiple other complications, like as in any hematology patient comes through, febrile neutropenia, multiple infections. This patient also has some Bell's palsy, neuropathy. So all these has been taken care. So right now the patient is on the 4 cycles, doing completely well. So the translocation cells is the reason for all this proliferative capacity and resulting in undifferentiated growth for this patient. So case number 2. She is a newly married, married since 15 months, 24-year-old young female with the primary gravida, who was basically referred for refractory anemia. That was the thing. And as we are very much aware, every patient before coming here, especially with anemia, would have been given loads of iron and B12. So this patient with a gestation of 15 weeks, RH negative pregnancy, and refractory to refer for the refractory anemia. So obstetric history wise, nothing, spontaneous conception with booked and immunized. Again, the hematology consult, symptoms wise, there is only mild malaise, no other symptoms was there, no history of exertional dyspnea, no jaundice, which usually tends to be in hemolytic jaundice. No history of any fever or no history of loss of weight, loss of appetite, no comorbids. So no history of any bleeding. Again, the family history, because this patient had a hemoglobin 8.2, we always tend to go to get the family history. Sometimes the consanguinate marriage can result in is possible. So especially the hemolytic anemias like thalassemia, sickles, all are there in our mind. But the family history was insignificant. There was no history of any transfusion in the family also. Her past medical history was also negative. So history wise, nothing we could get apart from mild malaise. Again, examination. Again, it's mild pallor was there, no stress, cyanosis or clubbing, no palpable nodes. However, an examination of abdomen, there was mild hepatomegaly and mild splenomegaly. Again, it is sometimes vague. This need not correlate with anemia most of the times. So if you see the blood work, the hemoglobin is 8.2, which says she is severely anemic. But the MCV, it's almost near normal. So generally we tend to keep a MCV cutoff of 80 to 100. This patient had slightly higher, maybe 1 or 2. Sometimes it could be macrocytic picture also. Apart from that, if you see the blood work, the reticulocyte was slightly higher. It's 3.5%. Generally we keep a cutoff of 0.5 to 2 as the reticulocyte percentage. Anything more than that is considered as high. Again, this has to be closely watched because sometimes there is something called as corrected reticount which has to be seen for the degree of anemia. Still, the patient had some sort of increased reticulocyte count. However, the DCT, ICT was negative. Lab wise, LD was again slightly high. The normal range is somewhere around 220, so it's around 300. Again, the patient had mildly icterus like 2.8 with indirect bilirubin of 2.1. Again, it's in favor of a hemolytic picture. So reticulocytosis is there, LDH is high, the bilirubin is high. However, the DCT ICT was negative. So we are dealing with some sort of a hemolytic, that is non-immune hemolytic anemias. So however, the peripheral smear did not show any spherocytes or any target cells or anything related to the hemolytic anemias. HB ultrapulse was done, which was normal. ANA profile was done normal. Apply profile was done normal. Even we have vented with osmotic fragility to rule out the hereditary spherocytosis, again which was normal. So basic workup did not reveal anything. So again, because we are not able to get anything, again the parental dose of iron was given, no improvement. B12 correction was given, no improvement. Again, we recheck the smears. Sometimes these patients tend to evolve with some sort of diagnosis, especially even with leukemias, lymphomas. At presentation, the patient may not be having any symptoms. Over a period of time, even after 2 weeks or 4 weeks, the patient can develop some sort of abnormal cells in the marrow. So we did smear which did not reveal anything. Cytosis, the DCT again came negative. So again, what to do next? Again, we went with the bone marrow. Again, bone marrow did not reveal much. It just showed some hypercellular marrow for our age with erythroid hyperplasia. There is also a megaloblastic maturation. Again, which says that it could be because of some nutrition deficiency. However, the B12 levels are normal, folate levels are normal. We also given adequate parental correction of B12, which was not, still the patient, the hemoglobin was not come up. So again, it just showed a productive marrow. Again, did not say any other apart from this marrow pathology. So again, the possibilities we came to a step one. It could be immune hemolytic anemia, it could be non-immune hemolytic anemia, or some congenital hemolytic anemias. So because we were not able to pick up anything, we went with the genetic workup, what's called the NGS, that's next generation sequencing for hemolytic anemias. So in the meanwhile, because we were in terms of hemolytic anemia, we are given some dose of steroids because the patient is 15 weeks of gestation, and the clinicians are very much worried the patient hemoglobin has to rise, and she's also RS negative pregnancy. We cannot give some multiple transfusions for her also. So this is what the NGS revealed. So to our surprise, it came to be something very rare. It's called as congenital dyserythropoietic anemia, type 1A. So it's extremely rare because these these diagnoses can be picked up only by doing a genetic workup. Despite if you do multiple other workups at multiple other levels like peripheral smear, bone marrow, nothing can be revealed. These can be picked up only by doing the genetic workup, especially by doing DNA analysis. So this patient turned out to be CDA type 1A. Unfortunately, she's like type 1A, because if it is type 2, she would have landed up in a transplant at the earliest. So this patient again, because it's type 1A, it's even literature wise, it's usually occurs in the neonates, but this patient landed up in the early adult because she is asymptomatic, and the transfusion cutoff was kept as 7, and she was closely monitored throughout the pregnancy. She never received any transfusion throughout, and again the family members are counseled. But the only curative regimen here is hematopoietic stem cell transplant, which is indicated only if she is symptomatic or if she is recovering multiple transfusion. Because this patient is fortunate enough that she never had any transfusion history, so we just had a close monitoring, and the patient is still under follow-up. She is doing well. The hemoglobin is going to be somewhere around 8, it's not going to increase at all. So again, what I am trying to say is not all anemia or iron deficiency anemia or nutrition anemia, because many times we tend to see that any patient who was having anemia, they will be like loading with lots of iron and B12 tablets and injections, which may not be required. So for the PGs here, how we will classify anemias. So basically there are multiple classifications or multiple algorithms which can be used, but we generally tend to pick up as MCV, mean corpuscular volume. So anything between 80 to 100 is considered normal. If it is more than 80 is considered microcytic. If it is less than 80 is considered microcytic. For the basis of understanding, microcytic anemias could be generally only iron deficiency anemia or thalassemia. And the easiest calculation menstrual index we can tend to find out. These may not be exact replica. Sometimes there will be some variations also. So coming to the case number 3, this is a 61-year-old lady. Again, she was presented to cardiology department with complaints of fever, which is for 3 days, with fatigability, malaise, and mild dyspnea and exertion. That's why she landed up in the cardiology department, and she is under consult under our cardiology for a long time. So also she had some vague history of loss of weight, appetite, and easy fatigability. Again, examination, nothing was there apart from she was completely afebrile, hydration was there, pallor was there. Apart from that, nothing was like no edema, no palpable nodes, no hepatosplenomegaly. Even vitals was relatively stable. So if you see, this was the counted presentation. Though the platelet hemoglobin again was very low, it is 8.1. Again, if you watch keenly, the poly is only 9%, that the neutrophils are only 9%. It's only of lymphocytes and monocytes. Again, typically we come across with any sort of viral infection, like even this pattern happens with infection mononucleosis. So basically we were thinking in terms of some sort of infection which is going on, but we have given some, the biochemistry wise, everything was normal. So we thought it could be viral induced because she had just fever for 3 days. So we just waited for the counts to recover. We waited for 1 week, no recovery. So again, the peripheral smear did not reveal anything, just a dimorphic anemia, macrocytes with the normocytes with neutropenia. So again, because the counts were not recovering, despite after waiting for a week or so, the polypops are still less than 10%. So we are thinking that maybe it may not be viral induced. We went with the marrow. Again, this marrow, it was a scanty, particularly hemolytic marrow. Again, it's a completely packed marrow. Because of that, we were not able to get any aspirate. But however, it showed some monocytosis. Again, it gave us a clue that we are dealing with some sort of pathology related to hematology. Again, the biopsy again did not, it showed just variable cellular marrow with the monocytosis. Again, this we were thinking in terms of again some evolving aplasia, something like that. Again, we have went ahead with the karyotyping for this lady. This turned out to be monosomy 7. So monosomy 7 is, we see maybe this is one of the post karyotyping as far as hematology is concerned, because these patients ultimately will require some sort of treatment, chemotherapy followed by transplant, because this patient is not going to be helped with any sort of conventional therapies like all these nutritional based. So this patient, again, the patient just landed up with 3 days of fever. It's very difficult to convince the patient. Just the patient had some sort of hematology pathology. So we are termed as high risk MDS because this marrow did not show any blast. So the diagnosis, final diagnosis is a high risk MDS. So this patient, after explaining all the pros and cons, we have started on chemotherapy, and the patient is doing well so far. So if you see, this was the last counts on 13/6. The platelet counts is 3,20,000, and the hemoglobin is close to 10.8. The poly, again, the neutrophils have come up very good. It's around 60%. So again, what we are trying to say is all these patients will require some sort of evaluation. Even though we will have a high index of suspicion at the back of our mind, sometimes it's very difficult to convince the patient that this patient is having some sort of hematology pathology, especially MDS or AML, because all these signs and symptoms happen within a short span of 2 weeks. Even last month, maybe one of our relative of one of our colleague, so 1 month before, in the month of April, we have done the CBC. It was completely normal, but last month when he came, he had thrombocytopenia, on evaluation found out to be AML. Within a 2 weeks to 3 week span, these disease can evolve. So coming to case number 4, again 52-year-old gentleman, Mr. X, who presented to us with right upper limb swelling, right lower limb swelling with severe pain. So he also had a history of fever for past 7 days, loss of appetite, weight and early satiety with a dyspnea and exertion. Again, however, the patient did not have any bleeding manifestations. He also a known case of diabetic and hypertension, well controlled. On examination, he had severe pallor, gum hypertrophy, diffuse lower limb swelling with induration. However, there is no hepatomegaly, no splenomegaly, no palpable nodes. So again, the patient here, we got a clue that the patient is having gum hypertrophy with severe pallor and dyspnea and exertion. So on lab reports, it came, the WBC count is extremely high. It's like 1,26,000, and the platelets are only 12,000. So we are sure that we are dealing with some sort of leukemias. The poly is only 2%. Blast were almost close to 83% here. So now we are sure we are dealing with the AML, probably AML because of his age. So we have went with other biochemical workup, like LDH is very high, it is 4,500 odds. Uric acid is again high, it is 11.2. Otherwise, the calcium, other reports with pertaining to tumor lysis was negative. So the peripheral smear showed blast of 83%. The bone marrow aspirate showed acute leukemia. Biopsy showed acute leukemia. The flow was done here, it showed AML. And because he presented with the right lower limb swelling with the induration, we did a Doppler. Now it's extensive DVT, acute DVT. So again, now we know the platelet counts are very low, it's only 12,000. So this patient, of course, will require some sort of anticoagulation, but can it be given is the question. So if at all we are giving anticoagulation, what drug and what is the dose? Again, should we use, if at all we are not able to give any sort of anticoagulation, should we use IVC filters? Next question. Again, what will be the chance of bleeding? So there are lots of questions which comes into mind the moment we see the patient. So the chance of the need for anticoagulation and the chance of bleeding was explained in detail to the patient. However, the patient denied initially the anticoagulation in view of low platelet count and chance of bleeding. The same day after denial, the patient developed difficulty in breathing with the drop in saturation. The saturation went to 88% and started on O2 support. So when the D-dimer was done, was very high. It could be because of other things also, but the D-dimer was very high. It is 6,200 odds, and pulmonary opening was short, and the advice was CTPA. Cardiology opening, vascular opening, everything was short. So this patient, fortunately, this patient did not have any pulmonary thromboembolism. The CT revealed infective bar, inflammatory etiology. Sometimes because of the high counts, these vascular permeability will be altered, resulting in desaturation. Because all these WBCs tend to pack the lung vasculature, resulting in a decreased saturation. So again, the vascular surgery consult was sought, they advised for anticoagulation. The cardiology consult was sought, they advised for anticoagulation. Again, there was a discussion going on whether to give IV filter such patient. But again, as per the recommendation from ASH, that is American Society of Hematology, the only indication or the commonly what we do in our settings, like the use of IVC filter, is like any patient where we are not able to give anticoagulation, or any patient where the anticoagulation is contraindicated. These are the only subset of patients where we can go with IVC filters, or any patient despite an anticoagulation, if there is a recurrent pulmonary thromboembolism, then they are the candidates for IVC filters. So this patient, we have explained in detail regarding the risks, benefits and everything, and subsequently we started on low dose of anticoagulation with the LMWH and with the platelet cover, because when the platelet counts are extremely low, less than 30,000, the recommendation is that we have to give anticoagulation because there is acute DVT. The DVT thrombosis is most likely cancer induced, so we have to start on chemotherapy also. At the same time, we should prevent the bleeding. So in that way, we are given some small supports with the platelets, at least 2 platelets, and gave some anticoagulation. So he was initially started on lowest dose of LMWH with the platelet cover. The serial monitoring and the surveillance was done for bleeding. Simultaneously, he was started on chemotherapy also, because unless the chemotherapy or the cancer is getting relieved, the thrombosis is not going to be under control, or the patient is not going to improve. So because of all these comorbids, we cannot give intensive chemotherapy. Again, this intensive chemotherapy can cause thrombocytopenia, especially AML. So this patient was given a less dose chemotherapy, and the patient's symptoms improved. The dose was slowly escalated to 0.6 ml, and subsequently post chemotherapy the counts also started to recover. If you see, so this was the day 10 counts after chemotherapy. The WBC from 1.2 lakh it shattered to 700, and the platelet counts was 23,000 on day 10, and subsequently day 28 post first cycle of chemotherapy the counts completely recovered. The platelets count become normalized. It's 1.58. All the differentials got normal. So the blast went away, like it was vanished from the picture. So now the patient is under remission. So the patient, because of finances, has to be discharged on day 14 when the platelet counts improved to 30,000. Again, we have changed it to oral anticoagulation. And the patient, the basically recommendation is that we have to continue anticoagulation as long as the patient is on chemotherapy, or as long as the cancer is active. So he has to continue for 6 months, and the patient continue with the anticoagulation for past 6 months. Chemotherapy also completed. So far the patient is doing well, and which is also achieved remission. So basically these are maybe every week we come across such kind of patients. Many patients will have some sort of thrombosis. Even there is a patient in ICU now with the MI with the severe thrombocytopenia. We have to, it's a calculated approach. We have to assess the risk benefit every day, day in, day out. If there is no bleeding, patients clinically better, we will try to push some sort of anticoagulation inside for the thrombosis, and then we will have to take it from there. Coming to my last case. So she is again a 28-year-old female from Manipur. That was a time when the Manipur was completely there was lots of problems happening in Manipur. So she is studying in some university here. So she was referred to us for generalized tiredness. Again, dyspnea and exhaustion was there, class 2. However, she also had low-grade fever, loss of weight. She was actually obese, more than 100 kg, and she also had a loss of weight of minimal, somewhere around 5 kgs for her weight. Loss of appetite, easy fatigability, and the past history was little significant. Again, examination wise, there was just a pallor was there, nothing else was there. Right? No nose, hepatosplenomegaly, no gamma hypertrophy. So if you see the investigation, the hemoglobin is only 3.1, extremely low. But she just came to walking to her OPD. WBC was normal. The platelet count was good. That's 2.49 lakhs. The DCT and other workup was almost nearly normal. The nutrition like new iron B12 was done, was normal. The retic was low. If it is 0.87, usually for the hemoglobin of 3, even though we see it as normal, but if we do the corrected reticum, it is low. So I was thinking more in terms of something like PRC, that is pure red cell aplasia. But again, so the peripheral smear did not reveal any major thing, just the dimorphic anemia. And they have given a note saying that there is a Role formation to do a bone marrow. Again, it's in this forum I would like to thank our pathologists, because many times if there is some abnormality, I get calls day in, day out, maybe from every time we get a call saying that there is some pathology, there is some abnormality, please roll out. So my humble thanks to Veena madam, Sindhu madam, Sedhu sir for all such inputs, because all these small inputs changes the clinical scenario ultimately. So when we went ahead with bone marrow, it was very difficult marrow, it's very hard marrow. We were not able to get any particle at all. Again, I had a suspicion that this could be something underlying marrow pathology causing this complete infiltration of marrow. So again, the imprint smear we got, it's acute leukemia. The flow cytometry could not be done because the aspect was not there. Again, the biopsy showed acute leukemia. We went ahead with ISC, it showed a BALL. So why I am trying to say is that generally we tend to think that only when there is a drop in platelet count or when the WBC counts are low or high, we tend to think in terms of leukemias. But example is this patient when there is only one lineage deficiency, like only one cytopenia, like hemoglobin is 3.1. So apart from it, she never had any symptoms, just vague symptoms. Still, this could be some hematological malignancy like BALL. And subsequently the patient underwent chemotherapy, and she again during the course of chemotherapy she had multiple complications, febrile neutropenia, multiple infections, because she was obese, and it was very difficult to manage. And she also had a seizure in between that seems to be thrombosis with a superior sagittal vein thrombosis. We had our neurologist on board and we gave appropriate treatment. She went on all these complications peaceful, like she tolerated very well, and subsequently she also had Bell's palsy during maintenance, and again that was taken care, because we were thinking anytime the patient developed some sort of infections or some abnormalities, we always think in terms of recurrence of disease. Fortunately, the patient just 1 month before she had developed a Bell's palsy, but the MRI was done, it was normal. The CSF did not show any involvement of leukemic cells, no blast was there, and she was also given intrathecal chemotherapy as a prophylactic purpose. So the take home message is hematology is one department which we always think in terms of teamwork. It's a multidisciplinary approach. Even though we tend to check in most of the lab tests, but still we need to treat only the patient, not the values. Just because some values are low, we need not jump and treat. For this patient, like example, the hemoglobin of 8, we all know the hemoglobin is 8, but we need not transfuse that patient because the hemoglobin is low until we get the diagnosis. So always look for the trend, because no such single count is going to give some diagnosis. We always look for the trend rather than a single value. Not all anemias are iron deficiency anemias, and not all thrombocytopenias are ITPs. So always do peripheral smears, do bone marrow study if required, and some set of patients also require the molecular testings like karyotyping, FISH or NGS to get the final diagnosis. So sometimes only if we do all such tests, we will be able to do some sort of diagnosis, and then we will treat the patients. Thank you for peaceful listening. I'll be happy for questions.
Thank you, Dr. Sridhar. Very nice presentation. Any questions?
I am so happy that my own student, Dr. Sridhar Gopal, was able to catch, because the mind, if the eyes will not see what the mind does not know. So all these cases were real catches.
Thank you, sir.
And this congratulations should be extended to Dr. Veena and Sedhu and another pathologist.
Yes, sir.
My own relative from Kanyakumari, he was running from pillar to post in various hospitals. Then I told them, either go to Vellore or come here. They sought to come here, and I took him to Sridhar Gopal. He made the right diagnosis. He only made it, and he is doing well. Last week only he got discharged. And coming to the first case, because it relates to pediatric surgery, we used to see Burkitt's lymphoma. I still remember a baby, dark lady with a severely distended abdomen, Burkitt's lymphoma. We lost the patient. It originally was diagnosed in South Africa. Burkitt's, Epstein-Barr virus and HIV.
HPV induced, most likely.
Yes. And in that case, why was not axillary node biopsy done? It would have been a very simple thing rather than going for finally.
The thing is that yes, one thing, because the platelet counts are low, again it's not, even we will give clearance despite the platelet counts being less than 10,000 with the platelet support. Because the marrow shows something, so we are clear that the marrow is going to have something. So that's why we went ahead with bone marrow. If at all we are not able to pick up in bone marrow, obviously the next thing is to go with lymph node biopsy. We had a plan for again getting either excision biopsy or true cut biopsy.
What is bone marrow imprint?
That showed leukemia. That's the
What is the technique, imprint?
Sir, basically, once we are all able to get the aspirate, so we'll get the biopsy report. But the biopsy will just imprint on the slides. All these slides will just imprint in that way.
That's being done in other solid malignancies also.
Yes.
Again, most of them, like more than 80% of times,
It gives good information.
It is a dry smear of the soft tissue, cut
yes, in that
section.
way, sir. Yes.
You don't stain it.
We will stain, sir. We will stain, only then we will see.
It was colorful.
Yes, we will stain.
Thank you.
Pathologists will stain almost every slide. So you are.
Sridhar, very nice presentation.
Thank you, sir.
I have a suggestion. In future, select only 2 cases and present very slowly and allow more time for discussion so that it will be useful, And all those abbreviations, we are all aliens to all these medical terms, so use full extension and things like that. So many cases, it's difficult to comprehend, So
Sir, actually, I was of the opinion that only a hematology department is presenting today, till last Monday. Like last minute changes, I was not, maybe yesterday only, sir, I came to know that sir was saying.
If the forum is hematology, nice, but we are all,
Because
mixed group
last
of people.
discussion, I was of the opinion that it's only hematology department. Even I said the same to Madam.
Since he is dealing with red blood cell double basin platelet, he is forced to present. Any more questions? So I have a couple of questions to you.
Please, sir.
The first case, Burkitt sir was telling black children. It's common in black, I should not say this, it's commonly reported from African HIV patients. But the first patient retroviral negative, and the question is, how common you see retroviral positive in Burkitt's lymphoma in our region?
So we do see, sir. We do see the percentage varies, be somewhere around maybe 10 to 20%. Sir. We do see many patients just because retroviral is positive, it can lead on to lymphomas.
The other case, the anemia with the discordant, inappropriately normal MCB, which is one of the common presentation which we see. In those patients, the hemolytic workup is normal, nutritional workup like B12 folate is normal. Should it lead to the genetic test in case in which there is no hypothyroidism or alcohol-related liver disease or so? Because that is one of the common problems that you see.
Yes, sir. If a significant anemia, which are symptomatic anemia,
Macrocytic anemias. I'm asking with reference to macrocytic anemias.
So macrocytic again, we commonly tend to see in the thyroid and alcohol also. Like alcohol history also should be ruled out. If other things, autoimmune, everything is ruled out, then...
Because there are situations wherein you have anemia, you have macrocytosis, B12 normal, folate normal, no thyroid, no alcohol history, no liver disease, no dietary intake. These are situations quite common. So in that case, should it lead to genetic test?
Depends upon the clinical scenario.
No.
Because what I will say, this patient sometimes if the reticulocytosis is there, because the reticulocytes are generally of bigger size. So sometimes the MCV will get masked. This will comprehend to the higher MCV also. Especially when patient with AHA, autoimmune hemolytic anemia, if you see the MCVs will be somewhere 140, 150 zone. So this is because of the reticulocytosis which is there. So this will, because if we take an average, the MCV will be on the higher side.
Okay, so this is the last.
This requires evaluation if required.
Okay, no, I do agree with you. The last one is the comment. The AML with a DVT in the lower limb, I don't think that patient would have required for a IBCFL, although you have not done it. Because this we see very commonly. You have pulmonary embolism, especially female in thrombocytopenia. We should start treating the basic pathology because it will improve most of the time. Of course, we should cross our fingers not to bleed. Because there is no pulmonary embolism in that patient. And obviously here the pathology is AML. We know with the treatment it should improve. And even with the IVC filter deployment, you need to give anticoagulants. The deployment of IVC filter is not immune not to give a drug.
No, sir, if it is pulmonary thromboembolism, yes, we have to give.
No. Even then, no, I disagree with the point, because even there is a pulmonary embolism, even if you deploy IVC filter, even then you have to give oral anticoagulants. Because deployment of IVC filter is not the indication not to treat these individuals. So we have to give heparin or oral anticoagulation, whichever you choose it.
That's what I was saying, sir. We need to give anticoagulation.
So in a patient in where the thrombocytopenia is non-treatable disorders,
yes, we
should not be going for an IVC filter.
So we will try to push as much as possible to give some sort of anticoagulation, minimal as possible, to make sure there is no bleeding in that case.
Yeah. So the point is, so thrombocytopenia is always better to treat, because these patients won't bleed even if you give a drug. Thank you. Any more questions? Yeah. So thank you, Sridhar, for nice, the millions, lakhs and thousands. Over to Dr. Shobi for her presentation.
A very good morning to one and all, and thank you for giving me this opportunity. And today I am going to talk about a very important condition which is seen exclusively in the pediatric population. And to make it more interesting, actually I thought I'll talk of zebras and horses, so I'll come back to it later. I'm going to talk about rickets. Rickets is the most common form of growing bone disease. It is because of poor mineralization of the growth plate cartilage. It is attributed to deficiency of vitamin D. There are a lot of genetic forms as well, and the causes could range from decreased skin synthesis because of decreased exposure. There could be maternal vitamin D deficiency, hypocalcemia and seizures, malabsorption. Hepatic and renal dysfunction can cause vitamin D deficiency, and the genetic forms wherein there is deficiency of 25-hydroxylase enzyme, which is important for the conversion of cholecalciferol to 25-hydroxycholecalciferol. This is vitamin D dependent rickets type 1B. 1-alpha-hydroxylase deficiency, which is responsible for conversion of 25-hydroxycholecalciferol to 125-dihydroxycholecalciferol. This is VDDR type 1A. Resistance at the receptor, this is VDDR type 2A, and the problem with the hormone response element which interferes with the binding of the vitamin D to its receptor, this is VDDR type 2B. And most of the times, based on the clinical features and lab parameters, we are able to come to a diagnosis as to what is the cause for the vitamin D deficiency in this child. So the diagnosis is established by a thorough history and physical examination and confirmed by radiological and lab investigations. So for example, this was a 2.5-year-old female child who came with deformity of the legs and progressive difficulty in walking. The child could not walk since the last 5 months, and there was lower limb pain. There was a very significant history of convulsions with fever, and at that time she was it was documented on paper that she had carpobedal spasms and hypocalcemia. There was no history suggestive of renal hepatic disease, malabsorption, polyuria or fractures. Birth, development and family history was negative. So on examination, this child was irritable, and she had no icterus or organomegaly, and she had florid signs of rickets. There was frontoparietal bossing, the anterior fontanelle was closed, she had 15 teeth with enamel hypoplasia, there was wrist widening, she had rachitic rosary, there was bilateral genovarum, ankle widening, double malleolus. So all the signs of rickets which we read in the books, this child came with. Her x-rays, the next step is always to get an x-ray done. So the x-rays usually show the changes at the wrist and the knee joint. So the changes at the metaphysis, where there is cupping of the metaphysis, which is the concavity over here, irregular borders, that is fraying, widening at the ends, this is playing. There is increased in the, the growth plate has become thickened over here, and generalized osteopenia and thinning of the cortex. So very classical signs of vitamin D deficiency, rickets. Her review of outside reports showed hypocalcemia and high alkaline phosphatase. So as is the general tendency, we normally start these children on supplements. So she was started on oral supplements, vitamin D and calcium. But even after 3 months, the reports remained the same. So the doses were increased, and later the vitamin D levels were quite high, but there was no improvement in the calcium and alkaline phosphatase values. It was at this point the child was referred to us. So, and over these last 6 months, the baby who was ambulating is now non-ambulatory. So the investigations from our side showed vitamin D levels which was quite high, but hypocalcemia, hypophosphatemia, high alkaline phosphatase, normal LFT and RFT. Ultrasound abdomen showed normal kidneys, no nephrocalcinosis. Urine spot creat ratio to rule out hypercalciuria was also negative. Parathormone levels were high, it is expected, secondary hyperparathyroidism due to the low calcium levels. This was the catch. So this is 125 dihydroxyvitamin D, which is the active form of vitamin D. So with very high levels of 25 hydroxyvitamin D, we have low levels of 125 dihydroxyvitamin D, which indicates it's a deficiency of 1-alpha hydroxylase enzyme. So this is vitamin D dependent rickets type 1A. So based on the history, the examination findings and the lab parameters, you can mostly come to a conclusion as to what is the cause. And then based on the diagnosis, you can treat with vitamin D and other supplements. So this child actually needed treatment with activated vitamin D rather than the normal vitamin D. So she was treated with calcitriol at 0.25 micrograms per day with calcium supplements, and within a month the calcium levels normalized, the alkaline phosphatase levels also started dropping. And within 3 months this baby was able to walk again. So that was a great source of pleasure for the parents actually. So improvement in the symptoms, the x-rays and lab parameters will reconfirm the diagnosis that what we did was correct. So this is the routine thing which we usually follow. So you treat, you identify, you treat, and then you see if there is a response. So with this background, I thought I'll come back to the title slide. So this was a very famous saying in our wards during our PG days. So during the rounds, our teachers used to say, when you hear hoof beats, you think of horses and not zebras. So what does this mean here? The horses refers to a common disease, which you see day in out, and zebras refer to rare diseases. So that makes sense, no? When we see a patient with a set of clinical signs and symptoms, you think of the common diseases first, rather than thinking of rare diseases. And that makes more sense because you're more likely to be correct. So in day-to-day practice, we come across various signs of rickets or vitamin D deficiency, very subtle signs, just an open anterior fontanelle, absent teeth, a little bit of frontoparietal bossing. So in that case, we always think of rickets. But sometimes you need to think that it could be the zebra as well. So that is what I'm going to show in the next few slides to prove this point. So this was a 3-year-old female child who presented with progressive leg deformity, no pain, birth and development normal, and as usual, because of this, she has received multiple doses of vitamin D and calcium supplements. Her anthropometry was normal. On examination, she had bilateral genu-varium. The dentition was normal. There was no other signs of rickets, no dysmorphism. The spine was normal. So point to be noted, only bilateral genu-varium, nothing else. So she had no investigations as such with her. So I just got her routine bone profile done. Her LFT, RFT was normal. Bone profile was absolutely normal. She got an X-ray done. X-ray is not showing any signs of rickets. There is no classical picture of rickets what we saw in the previous case. But what was striking here is that there is medial beaking and slanting of the proximal tibial metaphysis. This is characteristic of Blount's disease. So Blount's disease is a pathologic varus deformity because of disruption of the normal cartilage growth at medial aspect of the proximal tibial epiphysis because of excessive compressive pressure on the medial side of the upper proximal epiphysis of the tibia. There are two types, the infantile form which starts early in life, less than 4 years of age, and it is usually bilateral, usually seen in children who are a little bit on the obese side or they start walking early. So when I went back and asked the history, this child started walking at 10 months of age. So that is a risk factor for Blount's, and usually it is bilateral and it keeps on progressing unless it is corrected. The X-ray is very classical. There should be medial beaking and slanting of the proximal tibial metaphysis. Treatment is to use braces. They use knee, ankle, foot orthosis to keep the leg aligned, and if it doesn't work out, then the child may need surgical therapy. Earlier done, the better. Surgical therapy is usually in the form of tibial osteotomies and realignment, or they could go ahead with a hemiepiphysodesis where they may fuse or stop the growth on the opposite side so as to cause a realignment. So the next case, This is a 1 year, 7-month-old male child who was referred from our dental hospital saying that this child has no teeth, has lower leg deformity and a large AF. Please rule out rickets. This child had a birth history which was normal. He was the only child. Parents were distant relatives. The 4th generation grandparents were siblings, and the development was normal, and he had taken treatment elsewhere with calcium and vitamin D supplements, and he had actually a report of vitamin D21, which is not going to explain these findings definitely. This was the child. Anthropometry was normal. He was a very happy child with frontoparietal bossing, a very large anterior fontanelle. At 19 months of age, his anterior fontanelle was 6 into 6 centimeters. Normally we see around 2.5, 3 centimeters. He had a left-sided genovarum. He had no teeth, no other signs of rickets, no dysmorphism. The spine was normal. And then when I just got his lab parameters done, everything was normal. So even the vitamin D, the bone profile, LFT, RFT. So got his X-ray done just to see for signs of rickets. It did not fit into any of the clinical features of rickets. I got his X-ray done to look for the clavicles because the combination of large AF, tooth anomalies could indicate cleidocranial dysplasia. So I looked for the clavicles. Clavicles were intact, and this is the AF which can be seen, which is quite large. So at this point actually we were lost, we did not know what to do, so just continued the vitamin D and calcium supplements, asked them to wait for 3 months, but the child did not show any improvement. So finally we went ahead with a genetic test basically to rule out cleidocranial dysplasia, and this child actually, the report turned out to be a homozygous mutation in the BMP1 gene. This is bone morphogenic protein 1, and it codes for this disease. It is osteogenesis imperfecta type 13. So osteogenesis imperfecta, a brittle bone disease, is a heritable genetic disorder where there is severe bone fragility, osteoporosis, and decreased bone mineral density. 90% of the times it is autosomal dominant disease where there is a mutation in the COL1A1 and COL1A2 genes which code for type 1 collagen. The rest of the times you have these rare variants. I think they have listed some 23 types of osteogenesis imperfecta, and our patient had the 13th type. And it is an extremely rare autosomal recessive, moderate to severe form of AL due to homozygous or compound heterozygous mutation in the BMP1 gene. If you look at literature, less than 20 case reports in literature, and it has a very variable phenotype. So some patients actually have teeth. Our patient did not have. A faint blue sclera, severe growth deficiency, and fractures. Now since this child was young, he did not have any history of fractures, and he was doing quite well. We just planned to keep him under follow-up. Though in the case reports, they are using cyclical bisphosphonates, especially if the child has recurrent fractures. And the last case, this is a 5-year-old male child with poor tooth eruption. At 5 years, he had only 5 teeth. So he was referred from our dental hospital to rule out rickets. His birth history was not significant. He was an only child of non-consanguineous marriage. He had a very strong positive history. He had VP shunting done at 11 months of age. So that paper actually mentions that Arnold Chiari malformation with aqueductal stenosis and obstructive hydrocephalus. So at 11 months he had some developmental delay and visual complaints, and therefore he had to undergo the VP shunt. At present the development is better. Speech is delayed, but he is able to communicate. He goes to a special school and he has poor vision. He is under follow-up with the ophthalmologist. His anthropometry showed his height and weight below the 3rd centile. He was dysmorphic. So actually, this is the side view. He had proptosis and he had a left-sided esotropia. And if you see, he had low set ears also. He had a right VP shunt in situ, only 5 teeth, pectus carinatum, a right-sided genovalgus, no wrist widening, double malleolus, spine normal, and a just palpable liver. So again, some here and there features of vitamin D deficiency query rickets. So his investigations, however, except for a hemoglobin of 10.5, the rest of the reports were fairly normal. So it does not fit into a classical picture of rickets. This X-ray I got it done just to look at the bone age because his height was on the lower side, and this showed. This is the bone-in-bone appearance. This is the end-of-bone appearance, and we can also see that there is increased bone density over here. This is the marble bone appearance with loss of corticomedullary differentiation, and there is encroachment of the medullary cavity. So I got his screening done, and this is the Harlequin mass sign where there is thickening of the diploic spaces, and Harlequin mass sign is because of sclerosis of the orbits and the sphenoid wings, and you can see there is generalized thickening of the diploic spaces and diffuse density in the cranial base, right? This is expansion at the long bone metaphysis, and there is funnel shape of the lower end of the femur. This is known as Erlenmeyer flask deformity. And if you look closely, there are alternating lucent and sclerotic metaphyseal banding. These are areas of increased bone density at the vertebral end plates. This is known as the sandwich vertebra or the radial spine. So the diagnosis here was osteopetrosis. So osteopetrosis we confirmed, we did a genetic workup, and he had a homozygous mutation in the CLCN7 gene, which codes for autosomal recessive form of osteopetrosis. Now, osteopetrosis is a group of metabolic disorders which affects bone growth and remodeling. So the problem is here with the osteoclasts. Either the number is low or they are defective. So that is why the bone resorption does not take place. So the bone is going to keep on getting deposited, and that is responsible for this disease. There are 4 main types, of which the most severe form is the malignant autosomal recessive form. This is the mutation. This is what our patient had. It's quite rare. It is 1 in 2.5 lakhs. So this is the severe form of the disease. And if you look at the clinical features, our patient had all of this. He had just started developing anemia over a period of time because of bone marrow failure. He is going to develop the other features as well. He has visual impairment, and now this is going to be attributed to the narrowing of the cranial foramina, which is causing atrophy of the optic nerve. And he had the CNS involvement. That also possibly could be due to the same phenomenon. There is the increased thickness of the skull. There could be aqueductal stenosis as well. The treatment is supportive. There is no known cure. These children are prone for fractures, arthritis, and lot of complications like non-union, delayed union, and osteomyelitis, because the blood supply is compromised, because the medullary cavity is getting encroached. They need a routine ophthalmologic evaluation, routine dental evaluation. They are prone for dental abscesses and osteomyelitis of the mandible as well. Osteopetral rickets is a renal entity where you have some features of rickets with osteopetrosis. You have to be very cautious when you treat them with calcium and vitamin D supplements. And the final treatment is bone marrow transplantation, for which this child was referred to the hematologist. So I had referred to Sridhar sir they've been counseled for a bone marrow transplant. Should be done as early as possible before the complications start happening. So the take-home message is that rare bone disorders may sometimes present with common signs and symptoms of rickets. So the absence of a classical clinical radiological findings of rickets, or if there is poor response to therapy, we should become cautious and start thinking of other things. So we modify the thought now. We say when we hear hoof beats, you think of horses, but be prepared for zebras. Thank you.
Thank you, madam. Very nice. You agree with you, all these are zebras.
Yes.
So any questions? So we have pediatricians on board today. So before we ask, I'll ask a question to you. So what are the situations that you think of doing 125 hydroxyvitamin D as against 25 hydroxyvitamin D? Because commonly it is not asked at the first step. You wait for some time, then you repeat the profile, you still think, and then you go. And if that is so, what is the percentage of patients that you see this kind of lab parameters as like the first case? Because diagnosis should be reached to pinpoint to give a very simple treatment for the devastating problems.
Yes.
Your take.
So the initial step is to do only the first line investigation. So only 25 hydroxyvitamin D is the first choice always. But when we have such cases where there is no response, a lot of times even in hypocalcemia, which is not correctable, not only rickets. So children who come with seizures, like we usually see newborns with seizures, and the hypocalcemia, we keep on giving calcium and it doesn't get corrected. That is also the other scenario where we do 125 dihydroxyvitamin D to check if there is the deficiency over there. And most often it is for all these vitamin D dependent rickets, type 1A, 2, and all those. Like in type 2A, the 125 dihydroxyvitamin D levels will be very high because of the resistance. So only when there is a suspicion we go ahead with this test. This test is expensive. It costs around 5,000-6,000 rupees. So we don't do it very often, sir.
Okay, so you still think of that, the vitamin D metabolism disorder, then you have a presentation, you go to the next step.
Yes.
Because I think for the PGs that is a carry-home message today, because to chase a common problem is what matters a lot in a disease wherein it is very much treatable.
Yes. Calcium is high, yeah, we do it.
That also. They've had 2-3 cases and Dr. Shobi also was involved. The calcium is high and then we test why this is high and we check the vitamin D. The 25-hydroxy is normal. And then we see the 125 is very high because the degradation doesn't happen.
The
So-
metabolism does not happen.
Yeah. So that we have seen a few.
Any questions? So, the last question to you.
These things, all this, the flask deformity, Ramakrishna deformity, the sandwich appearance, all are fancy questions 20 years ago in all question papers. And as a student, we used to see all this in a pediatric ward. What's your thought, even after so much of revolution in the food industry, still you continue to see these problems in OPD visits with the typical rickets manifestations?
The typical rickets manifestations, except for these genetic forms of rickets and and those rare phosphopenic rickets, we don't get such chloride rickets nowadays because of nutritional causes. All babies are receiving vitamin D supplements right from birth till 1 year of age. So we just see the subtle features which just indicate the minor deficiency, sir. So whenever they come with florid signs of rickets, definitely there is something more to it.
Yeah.
So we need to
those
be
are
cautious.
more. So those are not horses, really zebras.
Yes, sir.
Thank you. So any more questions? So thank you all for coming today, and we will meet in the next clinical meeting. Thank you. Thank you to both presenters.